My name is Dr. Ekpunobi, and I'm going to be presenting interventions to reduce the length of stay in acute decompensated heart failure. This is phase 3. Over the 3 years we've been doing this of our QI project. It's presented by the authors, Dr. Karabajakian, who is our attending cardiologist, along with the residents, Dr. Abuaita, Dr. Siddiqui, Dr. Kalaydjian, Dr. Silliman, and myself again, Dr. Ekpunobi. This is out of the Department of Cardiology at Detroit Medical Center, Wayne State University. So a little bit of the background here. Heart failure, as we know, is a structural or functional impairment of heart function, cornerstone of the treatment in exacerbation being diuretics to offload fluid, and weight as well as fluid balance monitoring. In the literature, the mean length of stay for those with acute decompensated heart failure is about 6 days, 5.83 days to be exact, with hospital charges in excess of $11,000 and rising. This is a big problem. Increased length of stay is associated with increased mortality and morbidity and functional and financial burden, which also has its associated risks. The first 2 phases of this QI project over the past 3 years showed that there was decreased length of stay in patients who had their weight and fluid balance charted accurately. So the aim of this 3rd phase was to use a Foley as an intervention, Foley indwelling Foley catheter, to increase accuracy and ease of charting fluid balance in hopes to decrease length of stay, cost, and morbidity. Our study period consisted of span from July 1st, 2021 to December 17th, 2021. Inclusion criteria were those with diagnosis of acute decompensated heart failure, in addition to history of heart failure on the telemetry floor and an admission BNP of greater than 400. We excluded those without heart failure or a history of heart failure, those not on a telemetry floor, those with no recorded BNP, those on antibiotics, those treated for COPD exacerbation, and those on hemodialysis or with ESRD. So what we found was pretty interesting. We looked at 14 patients, 2/5 of whom were women, 3/5 of whom were men, and we found that the average or the mean length of stay was about 6.05 days, so somewhat in line with the literature. However, a length of stay with a Foley catheter was 7 days, whereas without a Foley catheter was about 5.33 days. So a fair bit of difference there. So our data actually failed to reject the null hypothesis, suggesting that there was no significant reduction in length of stay between patients with and without a Foley. In fact, actually, if the data is valid and you were to extrapolate it, it may suggest that placement of a Foley catheter was actually associated with an increased duration of hospitalization. The length of stay for those with Foley was about 7 days, which is about a day more than the cited average length of stay, and actually lengthier than the comparable population in the previous 2 phases of the study. Conclusions, however, are highly speculative given the marked limitations in the study. First, selection bias was a key player here. There was a low power of the study and there was poor randomization. Sample size was limited to only 14 patients, and the population varied greatly by pathology, comorbidity, severity of illness, demographics, and other factors which led to poor external validity. And it's likely that Foley was actually placed in patients that tended to be sicker, which did contribute likely to an increased length of stay. If we were to increase the power of the study by expanding population studied significantly and matching data sets across disease pathology and severity categories, likely would increase the generalizability of the study and reduce its confounds for more appropriate conclusions to be drawn. But it was an interesting phase. Definitely more study is warranted and definitely necessary.